Welcome to AETCM, the Emergency Medicine channel.
Yeah.
Today we are going to talk about 39-year-old female who came to the ER with perioral paresthesia, tingling numbness and muscle cramps in both upper and lower limbs.
Okay.
So on initial assessment, patient was conscious, oriented and able to talk. Airway was patent, there was no pooling of secretions. Breathing, air entry was bilaterally equal, no added sounds. Respiratory rate was 18 per minute and saturation was 100% in room air. Her BP, coming to circulation, her BP was 140 by 90 millimeter of mercury and heart rate was 86 per minute. All peripheral pulses were equally palpable. Coming to disability, her GCS was E4, V5, M6, pupil equally reacting both sides. Exposure, temperature was 97.8 degree Fahrenheit and GRBS was 132 milligram per deciliter. Adjuncts to the primary surgery.
Okay, we'll just hold on. Can you, age of the patient? 39-year-old. 39-year-old female presented with perioral numbness and paresthesia since how long?
Since morning.
Since morning. Before that, she was absolutely fine. Absolutely fine. So there was no issues. So perioral numbness and paresthesia presented to the ED, 39-year-old. Okay. And initial assessment, there is nothing. Airway, breathing, circulation, everything is fine. So what you done as an adjunct to the primary survey?
So we have sent for a VBG.
Venous blood gas. Why you wanted a venous blood gas?
So I wanted to look out for any electrolytic imbalance if was there.
Okay, which electrolyte imbalance that you wanted to look in here?
Calcium specifically.
Calcium specifically, what you will get in VBG?
So the calcium.
What you will get? What type of calcium?
Ionized
calcium. So what are the different forms of calcium that you know of?
So calcium is like 99% bound to the in the bones.
Okay.
And 1% is in the ECF, out of which 50%. Out of which 40% is bound to albumin, 10% is bound to phosphate, and rest 50% is free albumin.
So this ionized calcium is the main culprit here. Whenever a patient is having any symptoms, the most important culprit is the ionized calcium. So can you tell me the normal range of ionized calcium?
1 to 1.2.
1 to 1.2 millimoles per liter is the rate of, it is the normal ionized calcium. So you wanted to specifically look in for an ionized calcium. So reasonable to send a VVG, you can know the ionized calcium. So what was the ionized calcium for this patient?
0.9.
0.9. So how will you classify hypocalcemia? 0.9 is okay. So which all patient that you should be giving a calcium gluconate, or when ionized calcium is 0.9, it is not, it is low. But if it is less than 0.6 and all, you should definitely give. If it is like above 0.8 till 1.1, it's a borderline case. It is like a mild hypocalcemia that we are anticipating. So, for example, what all factors are dependent on this ionized calcium? What are the most important factors that is this ionized calcium is dependent upon?
So it would depend upon the vitamin D.
No. Factors in the sense vitamin D, I'm agreeing to it, but the thing is that what can happen in an emergency room, if it is like normal ionized calcium for a patient, what will happen if the patient started hyperventilating? So what will start the patient hyperventilating? Alkalosis. So alkalosis will cause what? The calcium level in the stores have nothing to do with this, but there is just a shift of calcium. As a result, there is a very low ionized calcium that is going to happen. So that is very important. So these are the factors which this acidosis, alkalosis, these are the factors that affect the ionized calcium. So ionized calcium is affected by this. So that indirectly causes the patient the symptom. Even if her normal calcium, she is having a normal calcium level. So that is very important. But this lady might be having a low calcium and maybe a low ionized calcium also. So that is different and this is different. So two scenarios are different. So we have went ahead and with a VBG. So for emergency room purpose, we have to think in terms of an ionized calcium, very important, because I will tell what are the other reasons where we should be considering an ionized calcium as a serious issue. We'll go after the discussion of hypocalcemia.
So there was no acid-base abnormality.
There was no acid-base abnormality. So what acid-base abnormality you are anticipating?
Alkalosis.
You can have respiratory alkalosis, but there is no respiratory alkalosis in this patient. The next adjunct what you have done?
So So we have also taken an ECG.
Okay. Why you want to do an ECG?
Sir, because sometimes in hypocalcemia we can also see some bradycardia.
Okay.
Or, so there can be prolonged QT interval.
Prolonged QT interval, ST segment can be prolonged, and QTC also can be prolonged. Or if ST segment is prolonging, automatically your QTC is also going to get prolonged, and finally they can go into arrhythmias. So they can go into white complex tachycardias, and they can have torsitis pointers, and all those things can happen. So that is very common. So you should take an ECG. And what was the QTC in this patient?
So it was normal. There is no prolongation.
No, I want to know the value.
Sir, it was.
You cannot think that it is normal, because for a female patient, what is a normal QTC? It can take maybe 450 to 480 milliseconds as normal, and adult patient little bit on the lower side. So that is one area females will have a increased level. So for QTC 480 you can take it as normal, maybe 450. So we should know the QTC exactly. Maybe a borderline QTC with an hypocalcemia, it can get prolonged at any point of time. Okay, so should know exactly what is the QTC. It was normal. Okay, I will take it as normal. So we can imagine that it is somewhere around between 450, less than 450, or maybe less than 480 also, since being a female patient. Then what are the other adjuncts that you want to do? So that's it. You just want to do 2 adjuncts, and maybe you can ask for a serum calcium level, which take some time from the lab to come. So what you will do for this patient? You will wait for your calcium level, or whether you want to treat this patient with hypocalcemia in the ED.
So since she was having too much of muscle cramps, and
Okay.
she was feeling very uneasy, so we started on calcium gluconate.
Okay.
So we started 10 ml of 10% calcium gluconate over 10 minutes.
So what happened after that?
So she did not get relief.
She did not get relief. Why she didn't get relief? Why the patient didn't get relief by giving one ampule of 10 ml of 10% alcohol? That is the question. Why she didn't get relief? Then what you did?
So we started on infusion.
Okay. So the problem, no, when in such situations, you might need to give somewhere around, if it is calcium chloride and we need a center line, maybe a 10 ml of 10% would be sufficient enough. But in this situation, to correct this, it will be only, you're not partially correcting the hypocalcemia only. You wanted to completely correct, maybe 2 to 3 ampules you need to give of calcium gluconate. Then only the symptoms will improve. So maybe a mild, because of 0.9, I agree that you give only 1 ampule, that is okay. But anyway, you're continuing as an infusion. What you can do is that you can maybe give around 2 ampules or 3 ampules, and you can give it over like 30 to 40 minutes. And you can see, rather than before the starting of the infusion, which will take further prolonged, like you are going to planning to give like 1 to 2 grams of calcium gluconate. But obviously that is not required for a borderline patients like this. Since she is symptomatic, you went ahead with an IV infusion protocol where what you did, you added 5 ampules of calcium gluconate to 5% dextrose, and you gave it over.
It was given over, sir,
6 to 8 hours. 6 to 8 hours. So that is again a very slow protocol. One more thing that you can do, you can take like 1 to 2 gram. It all depends upon the severity of hypocalcemia. If it is less than like 0.6 and all, you can give it even within 1 hour or 2 hours. You can do that. 1 gram, you can take it. 1 gram means how many ampules you need to take?
10 ampules.
10 ampules. What does 10% means?
10% of.
What does the, you said 10%. 10%. What does the 10% means? 10 grams in 100 ml. So 10 grams in 100 ml. So that is what you have to remember. So if you want to give like 1 gram, how much you need to give?
10 in 100.
If you are giving 25% dextrose 100 ml, you are giving 25 grams of dextrose. Okay, that's what we are going to treat the patient. So 10% of means 10% means 10 grams in 100 ml. So if you want to give like 1 to 2 grams, you can give what you have to give 2 to 3 ampules only. If you are giving 5 ampules, that means you are giving around 5 grams. So you are giving 5 grams, you have to give it very slowly only. I am telling you 1 to 2 grams. 1 to 2 grams means 2 ampules only you need to take. Okay, so that is a difference that you need to remember. So 10% of 10 ml will have how much? 1 gram. So what is that? The calcium content that the patient is going to get. Okay. So so you started on an infusion, and then you did what?
So we like monitored calcium every 6 hours.
Okay.
And also, so we sent for lab values.
Okay, so we'll come to when you are seeing a patient like this, is it our responsibility to go behind why this patient is having hypocalcemia? Yes, you have to evaluate. Unless and until you doesn't know, then you are not going to correct the hypocalcemia. So, what are the investigations that you wanted to send? So, what are the basic investigation when you see a patient with hypocalcemia coming to the ED? And I also wanted to know what is corrected calcium.
So we went this serum albumin I sent for because the corrected calcium is the serum calcium.
You have two options. You can either ask for a corrected calcium itself as an order. So there is no need of additional of doing an LFT and doing our manual calculation. So they will calculate and give it a value. Or otherwise they will do the albumin correction. The machine will do the albumin correction and give us the value. Or if you are getting already a calcium value and you already are getting an albumin value, then you can calculate by yourself. So every one drop of albumin you need to add 0.8 to the calcium level. Suppose the calcium level, imagine that albumin level is 2 and you take it as 4 as normal and the patient's calcium is 7, I am telling you. So for every one drop you have to add 0.8. So what is the corrected calcium? It will be 8.6. 7 plus 0.8 plus 0.8, that is 8.6. So it's almost the normal. So before you go in and start correction, you should know the corrected calcium. Don't jump and see the calcium is low. The next thing you should be seeing is the albumin. So one investigation that you said is this. Then next investigation, what you wanted to send?
Calcium, serum calcium.
Serum calcium level. Okay, we can know the serum calcium level. Okay, then.
So we can send for the creatinine because
Creatinine. Okay, and all other electrolytes. Which electrolyte? I'm telling you can send one electrolyte. Magnesium and one more electrolyte. Okay, magnesium and phosphate. These are the two things that can have adjunct deficiency with hypocalcemia. So the potassium is not very common, but this thing is very common with this. Okay, so then what other investigation you want?
So we want to send for vitamin D levels.
Vitamin D levels, okay, vitamin D levels, and so that's one of the most common cause that you will see. Vitamin D deficiency causing hypocalcemia. That is the most common cause that you will see. Vitamin D level usually less than 20, less than 12 and all, you will get all this hypocalcemia. So what is her vitamin D level?
It was 15.
1.5. It is low, little bit on the lower side. Usually target is 21. Then what are the other investigation that you want?
So we were sent for like parathyroid hormone.
Send for a PTH level also. If the PTH level is low, what does it implicate?
It's primary hypoparathyroidism.
I'm telling the patient has got, she has got hypoparathyroidism. That is the only thing. The patient has undergone a thyroid surgery, then it is not a primary hypoparathyroidism. Maybe they have accidentally removed the parathyroid or anything. So that, depending upon the scenario, you need to take up the call. So these are the investigations that you wanted. And before that, going to that, what will be the worst clinical scenario by which the patient can come to the ED with hypocalcemia?
Stridor.
Stridor, okay. Then,
Tetany.
why stridor? Why stridor?
Muscle paralysis.
Why stridor? Stridor, I said agreed. Why stridor? I am asking you. Why the patient can have stridor? See, that will you will see in only patients with usually when they are hyperventilating, hyperventilating, and suddenly they can go into a phase where your vocal cords will become palsy because of the ionized hypocalcemia. They will see. I am asking a question: if you want bilateral vocal cord palsy or unilateral vocal cord palsy, you are going to have a vocal cord palsy. If you want bilateral or unilateral.
Bilateral will be stridor.
Bilateral. I want a bilateral vocal cord palsy if I am going to get. Why? What is the problem when you have a unilateral and bilateral vocal cord palsy? What will be the position of the vocal cords when you have a bilateral vocal cord palsy? What will be the position of one vocal cord when you have a unilateral vocal cord palsy?
Medium, paramedium.
It will be in the paramedium position. Both will be in the paramedium position. So, what is happening? The passage is preserved when you have a bilateral vocal cord palsy. But when you have a unilateral vocal cord palsy, one is moving in. So there is a time where you are getting very low air entry to that area. So unilateral is very dangerous. Bilateral is, I'm not saying it is not dangerous, but it will be in paramedium position. So there will be some patency of airway will be maintained. So that is one difference that you need to remember. So what will happen in tetany is that they not be in paramedium position. They both can be in central closing position, and that tetany they can stay off like this, and the airway will be totally occluded. So that's one of the worst thing that can happen, and you might need a surgical airway in that situation. So that is one. The next thing, seizure. The next thing is most important will be seizure, convulsions, hypocalcemic seizure. Then the worst will be what? Next thing, hypotension and arrhythmias. So this will be the worst things. Tetany and all those things is not dangerous one. If that means that this patient has got hypocalcemia or trosochine, chostoxine and all those things, that only gives that okay, this patient is having hypocalcemia. But the worst clinical features that you need to anticipate is one is seizure, one is your stridor, then or even they can come in unresponsive situation. Then the next thing that you need to remember is the arrhythmia and hypotension. If like it is less than ionized calcium is very low, like less than 0.6, they even can come with hypotension. So that is the worst thing that you can have anticipate. And generally when you go, and what are the other clinical features you can have? Weakness, paresthesia, numbness and all other clinical features the patient can have. So this is the most important. As an emergency physician, this will be our most concerning one. So when will you suspect hypocalcemia? Any of this clinical presentation? You are getting a seizure, you are not knowing the cause of any seizure, definitely you are looking for all the electrolytes. Among that, the most important one is again calcium. So these are the clinical features that you need to look at. Signs, obviously, paresthesia, numbness, and your tapping sign, all those things you can do. You can do a BP cuff and look for the troso signs and all those things. So that are the clinical features. Now, what are the common causes that you need to anticipate? One you said is hypoparathyroidism, primary hypoparathyroidism, not very common that you will see in emergency room. What are the other things that the patient who is taking on thyroid replacement? What we commonly see, the patient is who is on thyroid replacement. Thyroid replacement, two reasons. They might have had a total thyroidectomy. Accidentally parathyroid can be removed. And thyroxine itself can cause hypocalcemia. So the patient should be put on calcium supplementations. So they should be on calcium supplementation post thyroidectomy. Irrespective of whether the parathyroid is preserved or not, you are going to replace them with thyroxine. So that is one agent that can cause this. Then what are the other reasons?
So it can be due to hyperventilation.
Hyperventilation, okay then.
And it can be vitamin D deficiency.
Vitamin deficiency, most common ones then.
Chronic renal failure.
Chronic renal failure patient coming to the ED. That is another group of patients, CKD patients. Yes, they need to think that.
Acute pancreatitis.
Acute pancreatitis, okay, because of saponification, you can have hypocalcemia then.
So hypomagnesemia.
Hypomagnesemia. So these are the common reasons why you have, but our aim is to correct that calcium and all. But one more thing what we usually miss in the ED is that, not miss, this can be an issue. We are treating a patient with severe metabolic acidosis. Imagine a patient with metabolic acidosis, what will be his respiratory rate? It will be on the higher side. Okay. The problem, because we had a patient, that's why every time whenever I hear about hypocalcemia, I want you to know about this, because the patient was hyperventilating, definitely because of to maintain the normal acid-base balance, the patient will be taking more and more breath. So as a result, there will be some amount of respiratory washout also. So at that time, there can be ionized hypocalcemia. So what are the drugs that you are using for your induction agent? Sometimes you will be using fentanyl, and all those drugs can be used. So fentanyl is one agent which can cause what? Muscle rigidity. Some point of time it can cause muscle rigidity. And what can happen is that this patient can suddenly go into tetany when you are using these drugs. Okay, so when you are trying to intubate, even if you give paralytic agents, that tetany will not be resolved. So they will be just like a lockjaw, they will again go into the ED. So when you have a patient like in metabolic acidosis, before you give your induction agent, just make sure and see what is the ionized calcium level. If it is below like 1 and all, it is better to give 1 calcium. There is no recommendation, you won't see it anywhere, because this is personal experience what we have seen. Whenever we have a patient with metabolic acidosis, specifically when you are suspecting a scenario like acute pancreatitis, where definitely you are suspecting a hypocalcemia. So in that scenarios, you have to be very, very cautious. Just see the ionized calcium. Definitely you would have taken a blood gas. If it is less than 1 millimoles and all, it is advisable to give 1 dose of calcium gluconate prior to that, so that this events can be prevented. So that patient, he went into tetany, we need to go ahead with a surgical airway. And primarily what was the issue? He had an axillary abscess which has led into a sepsis, and he was going for an impending respiratory failure. So that is the reason for RSI for him. We had given him fentanyl, and that is the time he went in for this lockjaw. Even giving by succinylcholine of any of the paralytic agent, the lockjaw didn't get revert. So it might come back after 10 minutes. By the time you just imagine the airway is totally locked, you are not able to intubate, then it's going to be a difficult situation. So that is one practical point that I want to add. Just if you ask me for evidences, I don't have any evidences to show you, only personal experience, whatever I've seen. Just make sure that if it is less than 1, which we used to practice in the ED, if it is less than 1, just give 1 shot of calcium gluconate, ionized calcium. It is not going to create you any problem. Just 1 ampule you can give it, and after doing this, we haven't seen any of the such episode, because that has been the practice. So we have never seen such an event after that. So that's maybe 1 in lakh patient might happen, but there is no harm in giving a calcium gluconate unless and until you are having a normal potassium. So if you are having like a 2.7 potassium, don't go and give this. So if you have a normal potassium, then only use this. Otherwise, it can further worsen, it can cause into cardiac arrhythmia. There are no other contraindication, and you feel there is hypocalcemia, just give 1 ampule of calcium gluconate prior to giving your drugs. Okay, anything else that you want to add on? Okay, so basically the take-home message is that when a patient presenting with hypocalcemia to the ED, the worst clinical features that they can come with, so we need to suspect when a patient coming with this way is, 1 is seizure, 1 they are presenting with stridor, hyperventilation along with it, and arrhythmias and hypocalcemia. You need to suspect hypocalcemia, also hypotension and paresthesia numbness, which is the classical presentation, and you can diagnose it by doing a simple bedside investigation of an ionized calcium, and you can treat starting maybe 1 to 2 ampules of calcium gluconate, and also look for QTC in your ECG, whether there is any classical features, and you hunt the causes of hypocalcemia. What are the causes? Serum PTH you need to send, vitamin D deficiency, and all other important electrolytes are magnesium and phosphorus. And once you find it, you treat it with your calcium gluconate as a bolus, also as an infusion. And later on, when they are discharging them, you should be giving them oral replacement therapy also. Maybe 1 OD won't be sufficient. Maybe 1 TID might be required, 500 mg TID, maybe 1 gram TID also might be required for the patient. Okay, fine. Thank you.